public document. Therefore, any testimony that is submitted orally or in writing, electronically or in person for use is in the public meeting process is public information and will be posted on the board's website. So let's call to order and start with introducing everybody. I'll start. I'm Ann Scharnhorst. I teach at Maui College.
I'm Mary Farmer. I also teach at UH Maui College. I'm gonna be presenting tonight, though. I'm not on the board.
I'm Clementina Seriulep, Dean for UH Manoa Nancy Atmos Ward School of Nursing. Good evening, everyone.
How about our Hilo friends? Arthur?
Oh, I thought it was ladies first. Hi, good evening. I'm Arthur Zambaga. I'm the Chief Nursing Officer at Hilo Benioff Medical Center.
New title. Thank you,
Yeah,
Arthur.
I gotta get used to
Love
that.
the new name. Hi, I'm
New
Jeanette
name.
Kawakami, director at the School of Nursing UH Hilo.
Hey, Jeanette.
And I'm Linda Beechnor, and I'm on this board and the board of directors for the Hawaii American Nurses Association. I'm the vice president and executive director there.
Thank you. And I am Laura Reichart. I'm the director of the Hawaii State Center for Nursing.
Woohoo!
Catherine, you want to go next?
Sure. I'm Catherine Finn Davis. I have multiple roles, but tonight I am here as the Associate Director of the Hawaii State Center for Nursing, in charge of evidence-based practice programs for the state.
Thank you for that.
Thanks, Catherine. Carrie?
Hi, I'm Carrie Oliver. I'm the nursing workforce researcher at the Center for Nursing. Woo!
The bomb.
Hi, Brianne Kuwabara here at the center. Board support.
So it looks like that's the whole family right now.
We got the whole
Take her-
family.
Take her away.
And we don't have quorum. 1, 2, 3, 4. We don't have quorum, but Rose and Gloria are scheduled to come back in. Carrie, were you saying something? No, okay. Sorry, I looked up and I thought you were revising. We don't have, I just want to say for the protocol issues, we don't have anything that's informatory. It's not, or it's informative. It's not, we don't have anything that needs votes. So I think we are okay to proceed because there isn't anything that requires a vote. And if we have anyone join in us, then we will meet the quorum. So with that, we can move on.
Okay, so all right, Mary. Mary's gonna talk to us about the LPN innovations.
Great. Yeah, okay, there it is. All right, next slide. So the LPN innovation is a lot of people coming together. Many of the different entities on the screen here to meet workforce needs in nursing, particularly for practical nursing. UHMC, Ohana Pacific Health, Hawaii Healthcare Association, Hawaii State Center for Nursing. Even we've had Hawaii Health Systems Corporation involved, Holly Makua on Maui as part of OPH, and also Kaiser Permanente, and others as well. This is the majority of the community partners. Next slide. Here's some images of our first cohort. We had cohort 1, which they just graduated in December of 2023. 31 students across the state earned their certificate of achievement in practical nursing and are currently getting authorizations to test and testing for the PN board exam. Next slide. This is a little bit about the timeline of the program. It can be completed in about a year. Once the prerequisites are done, which could be done in a fall semester, admissions are in spring. Then we go an 8-week summer session. So we do a full 16-week spring, an 8-week summer, and a full 16-week fall. And then they're eligible to graduate and sit for the NCLEX. Next slide. We just admitted 36 new students for spring 2024. This will be cohort 2. Currently, the LPN program is working with 5 groups across the islands. We have 14 seats that were open to applicants who reside in Maui that were community seats, and the rest are Ohana Pacific Health employees, and these are CNAs. We have an additional 4 on Maui, 3 on Kauai, 3 on Hawaii, and 12 on Oahu. Next slide. Their clinical experiences are mostly in long-term care, Ohana Pacific Health facilities on all islands. We're also doing some outpatient clinical experiences through Kaiser, Hawaii Health Systems, and also in Hilo this spring. They're getting opportunities in primary care, urgent care, peds, OB, and some specialty clinics as well. Next slide. So some of the takeaways that we've learned through this first cohort, many of the CNAs are required to work 20 to 30 hours a week in long-term care to maintain eligibility. And this curriculum is really designed to work around their schedule. However, you know, we have noted that it is quite a challenge for these students to maintain those work hours and pay their bills and do school. Some of them actually work other jobs besides just their jobs for Ohana Pacific Health. But we have also noted that these industry partners are very committed to help these CNAs succeed. So they are quite flexible in scheduling their shifts. We've also noticed that these industry partner staff invest a lot in these students because they know that they're going to be working alongside them after graduation. So there's a lot of really positive energy between staff members, our faculty members, our students, and of course these CNAs who work at a lot of these places. The other interesting takeaway is that OPH has really seen an increase in CNA applicants that want to be eligible for this program to become LPN. So that's something we were hoping for, and we're really starting to see that come to fruition now. Next slide. Or is that it? Plan for CNA Bridge for 3, spring 2025. We've got our ASIN self-study report coming up for fall 2024. We will be adding a cohort of 10 students from Molokai in the spring of 25, and we are planning to increase enrollments from the island of Hawaii. And next slide. Thank you. Questions?
Yes, hi, this is Arthur. I got a question. Excellent. I totally approve. I like it. Being an LPN myself, yes. One thing is they're all over the place. Who is the clinical preceptor or instructor?
So on Hilo, it is Hillary Keck. She is a lecturer for UH Maui College, but she's also employed by Ohana Pacific Health. So it's like a dual role instructor. And on Kauai, we have an instructor, and here on Maui, we have two instructors. So we
Okay,
have,
no, that's good. At least someone we can make contact with.
yeah,
if we need
that
to.
would be Hillary over there. Mhm.
Okay. And my HR has her contact information, I believe. Did you? What is she?
Probably, I could,
Okay.
she has a UH email address I could put in the chat.
Okay, please do. Thank
Okay.
you.
Thanks, Mary. I'm just so happy that you're giving this presentation because we know, and Carrie's going to talk about this in a second as well from the data perspective. The data is so concerning, right? The trends in our LPN workforce is so concerning. And so hearing about your innovative strategy is something that brings hope. Can you talk, I think there's two common themes that is addressed in kind of the general narrative pretty frequently. One is the amount of time that it takes to get eligible for the prereqs and, to qualify to enroll into the LPN program. So I was hoping that you could talk about your strategy a little bit about that. And then the second is, I'm trying to find it on the slide. On the takeaways, you talked about how OPH is seeing now an increase in CNA applications because they want to go into it. So you're kind of driving and growing a pipeline into the CNA as well as the LPN. And I was hoping that if you have any insight about that or a little bit more conversation that you could share if you could.
Yeah, so a couple of things. One of the interesting things was we got some funding to actually pay for some of the prerequisites from Good Jobs, from the Good Jobs grant. So we have had students getting those prerequisites paid for. We've also had a lot of grant money go towards helping them prepare for the TEAS exam, which is the pre-entrance exam that they need to get into the program. So in terms of prep for the program, there have been a lot of support in helping these students get the prerequisites they need and the help with the TEAS. What was, tell me again what the second part of your question was?
The second part was how you're seeing that there's an increase in the CNA applicants. So
Yeah.
there's people who are working to become CNAs now. Is that what you're implying in order to qualify for this?
So what we're finding is from OPH has now a lot of folks out there, well, not a lot, but they have a few employees that are like talent scouts. So they go to all the job fairs and they help with recruitment of CNAs. And what they're finding is, the more that the word gets out, the more they're having people walk up to them or apply or come to them and say, hey, we've been hearing that we can come work for you, and then we get this opportunity to apply for this program. So one of the ways they're finding out that it's attracting new talent is just through being at job fairs and different places where people are walking up and asking. And I don't know exact data, but it would be really interesting to start collecting that data across the state and find out maybe how many people were matriculating into CNA positions for that reason. Yeah.
Thank you, Mary.
Mm-hmm.
Do we have any other questions for Mary? I really want to give my kudos, and I kind of alluded to it, but this has been a really innovative program at a time where LPN workforce and nursing education has been really constrained. And so to find innovation in both of those spaces collaboratively, I think just shows the commitment to you all, and Mary, for the team that you've built around you to pull this off, and also to expand it to other islands, not just keeping it on Oahu, but getting it out to the many different localities that are really in need of LPNs. So I just want to commend you for that really incredible work that you've done, and the impacts that you're having on our state.
Well, thank you. I appreciate it. I think that the students are, very feel very thankful and grateful for the opportunity. These students work really hard. You know, they're not the top students, right? They're not the students that would have necessarily had the opportunity to even go to nursing school. However, they are people in the workforce. They know the bedside, they're comfortable there, and they show a commitment to wanting to pursue you know, career in healthcare. And so for that reason, you know, they try harder, they work hard. So hopefully we'll have good board results. So far, we're looking pretty good. I think we've had nine tests out of the 31, and we've had 8 pass. We've had 1 failure. So we're at an 88% pass rate at the moment. So we'll see how it goes.
Pretty awesome. Really, you know, it's Herculean lifting that Mary has done to become the department chair in the same year we had accreditation, in the same year she started this program. I wouldn't recommend that to my enemy.
I wouldn't recommend that to anybody either. Yeah. I actually took my first vacation over spring break. So I think I took chair position in August of 22, and I actually just took my first vacation over this spring break. And so it was really, really nice.
And your kids cheered, I bet.
Yeah, they were pretty happy.
Nice. All right, super good.
So thanks everyone, and you know, for all the support across the state, and really for the Hawaii Center of Nursing. I can't thank you all enough. So
All right. So
okay.
now Carrie's gonna hit us up with big data, yeah?
That depends on your definition of big, I suppose. How much time do I have so I can set a timer? Bree, tell me when I have to stop talking.
You have
12
17
minutes? 17 minutes. I'm gonna stop at 12. How about that? Because I will
Yeah, that
bore
sounds
myself.
correct. That looks like correct math, 12.
Okay, so hi everybody. Thank you for entertaining a data-related presentation. Was in keeping with focus on the LPN workforce. Happy to follow Mary. That growing the LPN workforce is kind of like one of the most important things that we can be doing as a state, and enormous kudos to Mary for the massive amount of work that has been. And so kind of what I'm hoping here is to show kind of the really significant importance, to put the importance of Mary's program and generally cultivating the LPN workforce in the state into context by talking about what the LPN workforce looks like currently. So we are, just as a side note, a lot of the things that we're going to talk about here today, we're putting out in our nursing workforce supply report. It is later than normally it would be, but we're expected to release that here in the next couple of weeks. It's in final formatting. And so in the report, we talk about the current state of each of the LPN, RN, and APRN workforces. And the themes of the LPN discussion in the supply report it is a rapidly shrinking workforce. It's almost terrifying how fast the workforce is shrinking. So if you look at a 10-year trajectory going backwards, we've seen a decrease in the number of individuals who've been licensed to practice as LPNs in the state of Hawaii, decreased by 40% over the last decade. Even slightly more alarming than that is the share of LPNs who are licensed to practice in Hawaii who are Hawaii residents has decreased by 48% over the past decade. So not only do we have fewer people who are eligible to practice as LPNs in the state of Hawaii, but the share of them who are actually residing in the state, and that can make a tangible here and now ready workforce, they're shrinking faster. And that's disturbing. It's distressing. So the question you should be asking yourself is, well, if we're, and this is something that happens like when we talk about nursing workforce and LPNs in particular, kind of at the national level, one of the questions that comes with, oh, the LPN workforce is shrinking, is immediately following that an adjacent question of, well, do we even use LPNs anymore? Are people still hiring LPNs? The answer to that question is yes, as a matter of fact. So if we just look at the DLIR's employment or projections through 2030, their long-term employment projections, they're estimating that throughout the state, employers are going to have to hire 90 new LPNs annually through the year 2030. And that is because of expansion in the LPN role and to cover people who have left their LPN positions. So rehiring to cover vacancies. 90. I'm going to show this to you on the next slide, but you want to guess how many LPNs we produce locally with our current programs? Currently, it's about 30. So it's about a third of what we actually need based on projected hiring going forward for the next, I don't know, however many years is 6 years. So there's that. So next slide. So kind of delving more deeply into employer demand, existing employer demand for LPNs. There are some states who are seeing a constriction of the LPN workforce sort of as in response to a decrease in hiring of LPNs, but in Hawaii, that doesn't appear to be the case, right? So basically what we're looking at here is that if you look at 2022 data from the Healthcare Association of Hawaii's Healthcare Workforce Initiative, which by this point is a little bit old, they are redoing that study as we speak. They're in the middle of kind of like putting that report together. But in 2022, the statewide LPN vacancy rate was 30%. 30% of all LPN positions were open. And I want to note that there was a decrease in the number of LPN positions that employers reported between 2019 and 2022. So that, when you consider that fact, and with the 47% increase in the vacancy rate between 2019 and 2022, we saw more open positions of fewer total positions. It is not surprising that like employers at some point who want LPNs in your workforce, because LPNs are a really nifty kind of workforce, right? Aside from the fact that they can't, I mean, strictly delegation is not in the LPN scope of practice and they cannot assess. They really function mostly like nurses, right? So they're this really nifty, cool place in the workforce where you can do pretty much all the really super important stuff except assessing a patient and delegating that an RN can do. They can pass meds, the whole 9 yards, and you get them considerably cheaper than you can get an RN. So from an employer impact, that LPN workforce is really important from a cost-effective standpoint versus what an LPN can do in your organization. But at some point, when you cannot get an LPN because they don't exist, you got to figure out how to adapt. So I don't know. I wish I knew more. I wish I had more information about how employers are adapting. So are you converting to RN roles? Are you shifting the responsibility of LPNs to CNAs with a supplement of RNs? Unclear. But you're having to figure out how to cover the responsibility of LPNs because you still need them and you can't get them. And like I said, that's 90 projected hires through 2030 every single year in a situation where we're losing LPNs annually. Next slide. So important then is to talk about where the challenges to LPN recruitment and retention are actually coming from. So where are the LPNs going? They're not just evaporating into the ether. Well, kind of they are a little bit. So starting with educational capacity, we're only producing about 30 LPNs annually locally. I think Maui's program is going to increase that number markedly. So we're going to enjoy an expansion of the LPN workforce for locally produced LPNs because of UH Maui College's program. So that's really important. And by the way, that once Mary finishes that accreditation, it will be the only accredited LPN program in the state of Hawaii. The other LPN programs are sort of not really programs. So Kapiolani Community College has an LPN program, but it is not accredited. Hawaii Community College had an LPN program, but they've suspended enrollment into that program. And Kauai produces LPNs pretty much only by way of their RN program. So people completing the first year of the ADN stop out, take the PN exam and practice that way. So in many cases, it's not really even proper LPN education, like proper programs, right? We are creating an LPN workforce by way of RN programs, which is terrible for retention because what you're doing is you're actually putting people who want to be RNs into the LPN workforce, which is great temporarily, but very difficult to sustain. And we're going to talk about salary as an impact to that here in a second. The other thing that's troublesome about LPN education is that when only the community colleges offer LPN programs, And so when the community colleges are told by their respective chancellors, like, oh, we don't have funding for faculty, or we don't have space, or we have to co-opt your space for some other program, the LPN programs are frequently the first ones to have resources pulled from that in order to preserve the operation of the RN programs. This is in large part what happened. Kapiolani Community College did this. Hawaii Community College has had to do this. In order to preserve the resources for the RN programs, we have to forego something, and it is the LPN programs that often have those, that they we set aside the resources for that. So in terms of creating a sustainable building of new LPNs locally, we have to do a little bit better. And public funding right now is the primary mechanism by which we are funding LPN education, but we're going to talk about the importance of academic practice partnerships, and Maui is a good example for that. One of the other challenges to LPN recruitment is when you talk about salary differential between LPNs and RNs. So if you look at the BLS data, which I thought about, but ultimately didn't put into the slideshow, but there's like a $60,000 difference in the average annual income between LPNs and RNs in the state of Hawaii. That's more than the difference in the tuition to go from LPN to RN. So essentially you can recover the full cost of your tuition in 1 year as an RN on average. So there's a really high return on investment for pursuing the educational level beyond LPN to go to RN. So when we look at the percentage of folks, if you put it this way, in our data, we're showing that 62% of LPNs in Hawaii make less than 60K annually. 52% of RNs make more than 100K annually, right? So when you set that as, when we ask nurses, hey, how can we incentivize you to continue in your existing position? The most common answer is pay me more to be here. So when you're talking about retaining a workforce, salary matters. And if you're talking about paying for 1 more year, really 1 more year, maybe a year and a half of additional education to go from LPN to RN, for that salary differential, it is very enticing. And so you really have to find the workforce that wants to be an LPN, which is really one of the things I love about Maui's CNA to LPN glide path model, is you're looking for people who've been doing like one of the hardest jobs in healthcare for a long time and looking to move into a nursing role. The LPN is a substantial pay increase from CNA. The autonomy of the practice is considerably different from CNA. It's bigger, it's better. There's more administrative opportunities there. So that's a really big step up. So recruiting CNAs into LPN as opposed to recruiting prospective RNs into LPNs, that's a much better way to create a sustainable workforce for the future. So salary does in fact have an impact on recruitment or retention for LPNs. The other thing that I think is important to note is workload for LPNs is hard and it's hefty. 16% of our LPNs in the state of Hawaii have 2 or more nursing jobs. It's almost 1 in every 5. And this is exactly what Mary was saying, right? Not only are these CNAs, they've got jobs, and those are CNA data, but still similar, right? So you got CNAs who are in a CNA role that is allowing them entry into Maui's Glide Path program. And then they have another job on top of that because they got to make ends meet, because Hawaii is the most expensive state to live in the country. So you got to figure out how to make that work. In addition to that, 27% of LPNs work more than 40 hours a week because they have multiple jobs. So across all of their multiple jobs, they're pulling like overtime hours on a typical week. And then they got to go home and take care of the kids and the kupuna and whatever else they're doing to manage life. That is exhausting and unsustainable for a lot of people on an ongoing basis. The other thing I think that's worth noting is that 30% of LPNs work in LTC post-acute care and 8% work in home health hospice. Post-acute and home health hospice are sort of settings where you're expected to take on a lot more autonomy. There's a lot less direct supervision, right? You don't have RNs necessarily watching over you in a home health situation. You might have one RN on a long-term care floor, but the LPNs might be running the show. So there's a significant amount of responsibility and autonomy associated with that job that you're expected to do for a considerably lower rate of pay. And that also can be a detriment to retention in the workforce. So I think all of these create a really interesting picture. So when, people pose the question of, oh, we're losing LPNs because employers don't need them. No, it's due to a bunch of other factors that the data clearly demonstrate here. So there is that. Next slide for me, please. I also wanted to note, I'm out of time. So really just to wrap this up, well-being, I wanted to note, we talk about in our supply report that well-being is really important to retaining a workforce in general. And we talk about the importance of employers committing to building workplaces that nurses want to be in. But I did want to note that although RNs report better well-being metrics, they're more likely to be satisfied, they're more likely to feel valued by their employer, they're less likely to have experienced an injury or have been bullied at work or to have sought mental health services to cope with work-related stress. There is no material difference between LPN's job satisfaction or their intention to stay in their current role. So this is one of those things where we really have to start digging into actual, how do we solve a workforce problem, as opposed to like, oh, let's just make nurses feel better and then they will want to stay. That is not how we sustain the LPN workforce for the future. Next slide. No? So how do we do this? How do we create sustainability for the future? Be like Maui, first of all, build LPN programs that make sense, right? Admit the right students to the right program, build prerequisites that make sense, set the T's admission score to appropriate to your recruiting, and then build those academic practice partnerships, get buy-in from industry, have industry pay for your clinical instructors, have them make the clinical placements that they want, that they need to build the workforce they want to hire available. So get that private investment in the education, follow Maui's model. It is a good thing. And then transition to support for unlicensed assisted personnel who want to go into LPN, exactly what Mary was talking about, getting that CNA into the LPN role. Find ways to decrease the cost of education. So streamline the prerequisites, find funding opportunities, get loan repayment, and then also implement new grad residencies for LPNs, which is a neglected sort of thing in nursing in general, but they need help to transition into a new role too in order to be successful. So the last slide I have is just the major takeaways. So we do still need LPNs despite our declining supply. Hawaii schools of nursing right now do not have the capacity to satisfy either existing nor future demand for LPNs. So we got to do something if we want the situation to be different. Employer investment in LPN programs is absolutely crucial. We cannot rely on public funding alone in order to make the LPN workforce sustainable into the future. And well-being isn't going to solve LPN workforce development problems. So we can, in fact, help. And if we can provide better access to LPN programs like the Maui Glide Path program is doing to folks who are like, I'm not good for an RN program, but man, I can do an LPN, creating those pathways and avenues, glide paths, whatever you want to call them, to get them into the education required for a nursing career. That's how we help solve that problem as well. So that's it. That's all I got. Not a super happy presentation, but I'm happy to take any questions if you have them. Boss said she can cede some of my time to me if you guys have questions.
Ditto.
I was thinking we need Pauhana drinks during this presentation.
Yeah, sorry. It was not a good time. I should have brought margaritas, right? Talk about
Make it go
LPNs
down a
and
little
drinks.
easier.
So I just
yeah.
want to make a comment in
Yes,
terms
please.
of support for the LPN training. I was at an HSCN Dean's Conference this past March, and what they're doing in some of the states is that they're actually asking for scholarship, full scholarship. This is for RNs, but I think you can do it for LPNs as well. So employers are being sought by schools of nursing to provide full scholarship. And in return, they will work 3 to 4 years post-graduation. Of course, there are metrics along the way that, they're progressing, etc. So if they don't complete the program, money is given back by the school or by the student, but post training, then giving back the money would be on the employer's side. So maybe those are the things we should consider as well.
So the employers are providing the scholarships, Clem. Is that where the money's coming from?
Yes, correct.
Academic practice partnerships.
Mhm. Yep.
And Clem, I just want to know, HAH called me last week. They were trying to work through that. What the best way for that employer partner partnership is it that student tuition, or is it the paying for faculty, kind of like we've been having in other spaces, those conversations in other
tuition.
spaces. Like what is the best way to make a program run? So not just covering the cost for the students, but kind of making sure that program is sustainable. And I think those are really necessary conversations. So thank you for bringing that up.
Mhm.
Other thoughts, questions? Well, then you can just wait for the supply report to come out here in the next, I don't know, days, like single digit days, pretty much at this point. So more discussion to be had. Thank you so much, everybody. I appreciate your time.
Thanks, Carrie.
Thank you, Carrie.
Awesome.
Okay. For the record, I just want to indicate that Rose Hata has joined us a couple of sessions ago. Alrighty, recruitment and retention programs update. Pretty dry, but depressing, but not quite as depressing as Carrie's. Transition to practice. So over this past year and a half, we have really expanded a lot of our activities under what we have been calling the Hawaii Nurse Residency Program. Well, we've discovered that the Hawaii Nurse Residency Program really ultimately is the operation of an RN new graduate residency program. And so we've decided to do a little bit of rebranding to make it more inclusive of the actual activities that we do. So as part of that, we are rebranding to a higher level, which is the Hawaii Nurse Transition to Practice, which will be known as HNTP. And under that, we will have our 4 programs as it stands right now. So we retain the HNRP, the long-term care post-acute NRP, the preceptor training program. We're going to kind of uncouple that from underneath the HNRP and have it be a standalone activity. And the transition to specialty training program, which we've been working on this past year. We have gotten a logo done. So we have our own branding, which is really exciting. And we'll be working to kind of update all of our resources on the webpage. So from here going forward, we will be providing you updates on HNTP. I just wanted to mention that we have a new graduate student. Chelsea isn't able to be with us today. She happens to be a Gepin student, so she is very, very busy. But it's wonderful to have her here. She's from California. She's got some research background. She's also a go-getter, and she fits in with our loud, boisterous team here at the center. So she's a good fit for us. I'm really happy to be working with her. Okay, nurse residency program updates. Just kind of provided a little bit of updates on the extramural funding for these with the HNRP. This is currently being covered as part of the opioid grant because we are delivering opioid content at all of our sites. And we're also delivering opioid content for those participating providers for the preceptor training program, also covered under the grant. We are due to lose that grant. It runs out 9/29 of 2024. We have reapplied for an extension to the grant, made some minor modifications to add some more robust kind of leadership level training. Keep your fingers crossed. We would really like to have it for another 2 years. It has made a substantial impact into our numbers. Overall, we're seeing a small decline compared to previous years for where we should be at this stage in the year for our nurse residency program. I still anticipate that we're going to be at the 360 to 370 mark by the end of the year. So it will be a bit of a decline. It's still substantial numbers, and it's still a significant increase from pre-COVID years. Long-term care post-acute. So this is the one that's really exciting, really, really exciting. We don't have a lot of participants for our pilot year. We have 2 partners that are currently participating. One is launched, up and running, doing a great job. We have another one that's taken a little slower to get off the ground. The long-term care post-acute is currently coupled under the Good Jobs Hawaii grant. So we are able to reimburse our partners who are participating under that grant, which is really great. So as long as we have those grant funds available to us, we will be able to cover the cost of that. I also want to make mention that we have also included the long-term care post-acute nurse residency program into our application for the DOH ADAD grant. So assuming that we get it, we should be able to help provide and kind of extend that out and hope that we get more participants to come on board with us for that program. Ultimately, this program really is going to end up being word of mouth. If the pilot works for one of these groups, we'll get more buy-in from other folks. So that's really kind of where it's going to make the biggest meaning, because this setting is a little bit more hesitant to make change, and they listen to each other certainly more than they'll listen to us. And we really are not in a very good position to provide any kind of metrics to them to justify them coming on board, because it is relatively new. But I'm pretty excited with 12 new grads and 9 preceptors in long-term care. Okay, preceptor training updates. We are also seeing a bit of a decline in our preceptor numbers for this year. I anticipate seeing a similar decline this year from what we had last year. And the main reason for that is we really kind of are at a saturation point. Just if you're looking at what's been happening since 2022, we're at 770 trained just to this part of the year. That is a big portion of our working nurses in acute care, where these programs are the most aggressive. So it'll be declining, but right now we still do have numbers. We also have a lot of anticipated numbers that are planned in a lot of our programs later on in the year. At least that's what I'm hearing. So that's very exciting. Preceptor training is currently covered under the ADAD opioid grant for partners that are providing the opioid training. Going forward, we've also included it in the ADAD reapplication, so hopefully it'll be there. Fingers crossed. Transition to specialty program updates. So this is really exciting, getting this up off the ground. We knew that we were going to have grant funds. So as part of Good Jobs Grant, we're able to cover the costs of this curriculum. We're also able to provide, by way of Healthcare Association of Hawaii, or Healthcare Association of Hawaii is able to provide stipends for a significant portion of these as well. So that's up to around 700,000. So we're almost at the cap for our earned stipends, but we're not quite there yet. And looking at our transition to practice programs, we are at participation of 659, which is pretty good for 1 year so far. So we're a year and a few months in. Those are pretty big numbers. And we can see that a lot of those are in some of our more critical areas. And so we're looking at a lot of OB and a lot of peds, which is fantastic. I also want to say and bring your attention to the very middle of this and look at Healthcare Leadership Certificate Program. That's pretty darned impressive. So, you know, we're looking at having some resources that our facilities weren't otherwise using in years past, and some of those tools and resources are new. Other ones we're able to help to take the worry out of those programs, and some of those our partners are reporting being able to enroll larger numbers of nurses than they otherwise would, because they know they're going to be reimbursed. So we'd like to think that all the way around, it's making a significant impact. A lot of that is because we have a grant. It's not going to go forever. At this time, we currently don't have any mechanism in play to continue to provide reimbursement grants for the transition to practice program, but we do hope that some of the mechanisms that we've set in place to allow group purchasing and statewide discounts will help kind of to sustain more of this curriculum in the workplace than we have had in prior years. Laura, you had your hand up? Okay. Okay. Clinical placements. So that was the good. Now we're getting to the bad. So recently for the Hawaii Clinical Placement Collaborative, we have had a software upgrade. we have gone from version 2.0 to version 3.0. This is the centralized clinical placement system that was developed by the Foundation for California Community Colleges that we have been using since 2011. This is the second upgrade that we've had since 2011. It has gone more poorly than anyone could have possibly ever expected. So we've run into a lot of problems that have created a lot of delays. And we should have finished our clinical placements for fall weeks ago, and we're still in the middle of struggling to try to work through all of the bugs in the system to get that in play. Ultimately, we've had problems with it happening in the middle of a placement cycle and it not going particularly well, and so that caused delays. We have had underlying historical data that it was erroneously changed by the developers without our prior knowledge or input into in any way. As an example, our historical advanced preceptor placements, so our, that highest level nursing placement has now been turned into allied health in our historical record. I don't know, they both start with A's. So that just gives you an example of some of those poor decision-making situations. We're currently working on all of that with the developers, and I asked them not to do it, to let me do it, and I will give them a table. We've also had problems with insufficient training. They provided a 1-hour update. That really wasn't adequate for anyone in any way, shape, or form. They didn't go over even half of the changes that they made in the system, also a problem. And lots of glitches, bugs, system processes that were broken and that have required updates. Now, they have been good in addressing a lot of the critical ones by working all week overtime with their developers to do a roll last weekend that fixed a lot of the most critical problems. We still have a lot of problems, but most of the problems that we have left in the software aren't preventing us from working. They're preventing us from working well. So, right now, at least we can work. The HCPC has a subcommittee that's looking at tools to standardize the onboarding forms and resources that our schools have to go through to do onboarding, but also to look at getting new tools to help with the requirements management and clearance process, which is something that's not included in CCPS. Now is not a good time to be doing that because all of our partners are now doing demos for other software systems right when we have a software system that's breaking. So maybe it's actually fortuitous. But our committee is meeting once a month and we'll continue to do reviews of alternative software once a month, also going forward through to the end of the year until we find something. Oh, we are this spring issuing a new projection study or a new clinical placement needs survey, which hopefully will lead into the issuance of the new projections of Hawaii nursing clinical placement demand. That was a nice report we put together a couple of years ago. We definitely need to update that. HAH is coming out with new data. We're hoping to be able to couple those two things together. And in doing so, it was supposed to be in play and being in draft time right now, but I can tell you that it has been delayed by a couple of weeks because now is not the time for me to be asking my clinical placement collaborative partners for additional data. So as soon as we get over the hump with our role, we should be all right. And I'm hoping to be able to pick up those efforts next week. Availability for fall. We continue to have issues that kind of always remain a concern. Right now, we have problems with some of our schools not being able to be very adept with being flexible, not being flexible with their clinical placement capacity. So when you got limited faculty, you don't have enough to go around, you have faculty that are doing other jobs, it kind of limits your capacity to take smaller cohort groups into facilities who may only be offering groups of 4. So right now that ends up being a hindrance to some of our schools. And more or less that hindrance makes a bigger impact on our state schools than it does on our private schools. Preceptors, I keep hearing, and we keep seeing that preceptors remain an issue. We were hoping that at this point in time, after COVID, we would be out of the preceptor pits, and we would actually start seeing activity on that front, and we would see new preceptors coming in. And despite a lot of all of the training that we've done in preceptor under the HNTP program to train our nurses to be preceptors, we're not really yet seeing any increase in the preceptor population that are available to us for clinical placements. Specialty areas remain a concern. They are particularly concerning in OB and PEDS because we have had some significant reductions at some of our facilities for those availabilities. Even one day makes a huge impact and stresses things. We are also seeing critical concerns in behavioral health. As you know, that environment has been in flux. We've had some issues with the state hospital and some other areas, and behavioral health really hasn't recovered since COVID in terms of allowing students in the door. But our schools are actively engaging in trying to make new community partnerships to try to fill that void and looking at alternative type placements that they normally wouldn't have in those settings in order to get those types of experiences. I'm done. Anybody have any questions? I am just at time.
I have a comment, or I have a bit of data.
Oh,
which
data.
Little data. We just, we've been enjoying all of our new grads being hired for a few years in a row. So this is the month we're setting up the interviews with the hospital. And 36 out of the 39 grads put their applications in. And they actually have 18 to 20 spots. So this is the first time where they really have not just been able to take everybody.
Wow.
And concurrently, I have a travel ED nurse living in my house. There's 9 travel nurses in the ED right now, and they renewed 0 of them. They said, all our residents are graduating and they're all gonna take the places. So to that remark you made, Bree, about hitting a saturation point, Maui Memorial is hitting a saturation point right now as far as RN staffing goes. We'll see what happens. It's just 1 year, but it is it's definitely a turn in the other direction that we've been.
Yeah, it'll be interesting to see kind of what is the post-COVID world and what is our supply and demand? What are those real needs going to be in the new world that we're working towards? So I'm sure everybody at the center is going to be working aggressively to try to dig out of that and to make meaning of all of the data that has been in flux up until this point. So hopefully we'll be able to provide some information back to everybody about what that landscape actually is going to look like.
Yeah, the nursing alumni last week, I was talking to Eric, the CNO from Adventist Health, and he said similar information to me and about his nursing RN vacancy. Yeah. So I think it will be very interesting what the HAH survey shows when we get it this summer.
Same here in Hilo. The past 2 years we hired 40. This year we're probably going to only hire 35. Can't make it up to 40 because there's no vacancies. But we still have a lot of travelers because these young graduates like to make babies as soon as they get a full-time job. So they're starting their families. Nothing wrong with that, but our travelers are short-term to cover the maternity leaves. And paternity leaves too.
Yeah.
That's important, Art, because
I know it is.
Yeah, because I went to a conference, they're saying that the United States is now below the replacement in terms of birth rate. So we're going to see a fall in the number of students coming.
Oh yeah, our deliveries here on the east side has been going down. So yeah, we see it.
Mhm.
See the decrease.
Well, I want to take a moment. It's been a really tough couple weeks for Bree with dealing with the data changes with the clinical placement system. And she's like, talk about a lesson in diplomacy. Like she's done a really good job being a fervent champion for our partners and holding the standard for the clinical placement system that we we can't get out of, right? Like we have to use it to get these placements for the fall, and she's making sure that that happens. So I just want to really make sure, if you didn't get that message in her presentation, that you are hearing it from me, that she has done an incredible thing for our state to really force this to a good place. And I don't think that that would have happened without her, or at least in the way that she has handled it. So Bree, thank you so much.
Well, thank you for the kudos. I don't deserve them, but thank you.
You absolutely do. You absolutely do. Okay, well, Bree took herself off the camera, so I'll move forward, but we can just keep on popping those hearts over for her, okay? The policy we're wrapping up on our session, our legislative session ends in just a couple more days. We have about 10 more days left in our legislative session. If we go to the next slide. I have broken up our quick update into two different sections. One is in workforce and then the other are the education bills. From the workforce bills, we knew that the Nurse License Compact was going to be introduced, and of course it was. We voted on it as an advisory board, and the Center for Nursing has been providing testimony and support along with the recommendations that were in the SCR 112 report and recommended by this board. The Senate bill died, and that it's kind of like a non-controversial process thing. They chose one bill to move forward. This is a governor's initiative, and it has flown through the legislative session. The conference, there will be a conference committee. There's a little bit of disagreement about the versions, and that just means that the Senate and the House are going to use the next couple weeks to determine the final draft that they send to the governor. I will be shocked if it doesn't pass. Right now, the effective date as written, which is requested by the Board of Nursing, is a 7/1/2026 start date. It was initially set 1/1/2026, so the start of the calendar year, and the DCCA has asked that it's changed to the fiscal year, which makes sense, honestly. With this, it is the Nurse License Compact, and then it has three additional changes. Those changes, or those three additional parts, is the effective date. So it would be the start date of 7/1/2026. And the second is that it would require that employers collect, or it requires employers to require their nurses that they hire under a nurse license or a multi-state license permission to practice to report demographic information to the Board of Nursing. So it would require this information to be submitted. As Carrie presented in several other venues, I think this meeting as well as in the Nurse License Compact study, that doesn't really have any substantive impact to the Center for Nursing from a data perspective. We focus our research on locally employed nurses. So you need a license and a residence here, basically. It may have positive impact for RICO, for the Investigatory Affairs Division, because it would make the information more accessible to them should there be any discipline problems. And then in terms of the financial piece, which is not part of the Nurse License Compact bill, that is handled already in state law or state rule. And so DCCA is able to amend fees or develop fees. And so they would have to create a new fee structure for a multi-state license for Hawaii. So the only fee increase would be for nurses who opt for a multi-state license. So like for me, I'm not going to be practicing telehealth in another state. I'm not going to be teaching across the nation, I really only need a Hawaii license. I'm gonna keep my single state license. Somebody else, like Jeanette, I'm just gonna name you because you're, you run a DNP program. You may have students who work in, or who live in other states. So it may be reasonable for you to get that multi-state license because it may have practice implications for you. So Jeanette may end up paying more money than me because I'm not changing my license type. So that would be the revenue increase. And the Center for Nursing right now, I am asking that we are included. We're included in that fee increase. And so it's not just RICO and PVL, but it's RICO, PVL, and HSCN that gets that a portion of those increased fees. But that doesn't happen legislatively. That happens in administrative rules. So it's a separate process. For temporary permits, I have it here kind of couched in these bill sections, but I just want to note that at the start of the month, which was April 4th, sorry, I'm looking at my calendar, April 4th, the Board of Nursing did hold a public meeting to review the proposed changes to the Hawaii administrative rules. They did pass. Essentially what it does is enable the Board of Nursing to issue a temporary permit if a nurse has a license in another state that's in good standing. That's kind of the most simple terms. It does not require, like in years past, that the nurse also submit an application for licensure in the state. So they will be separate now, but that doesn't also prohibit the nurse from applying for a license. So a temporary permit will be issued that would last 120 days. And at that same time, or anytime within that 120 days, or anytime after, they can apply for a license. So they're two separate things now, but very important because we have recognized that access to licensed nurses is very important for our state. And so this is helpful. Also, only 30% of the nation's nurses have a multi-state license compact. And so when you're talking about immediate access, you still want that immediate access to that other 70%, should they be looking to come here for whatever reason. Staffing ratios, the bill died, SB 1580. It was introduced last year, got reheard this year. It got turned into a legislative study. There was a decision making on today. I haven't gone and looked at what it was yet. But essentially what happened in the resolution, so the bill is dead. The resolution changed it to a working group to do a study on the efficacy or feasibility of having ratios and overtime in our state. And then there was a revision to that resolution that changed it to a legislative reference bureau study. And they opined that they don't really have expertise, but what they could do is a review of all the other states that have enacted such laws and a literature review on the same topic. And I think that is what will move forward if there is this concurrent resolution that's signed by the Senate and the House. If it's only signed by the House, it's not going to move through. Procedurally, usually that work isn't done. It requires the Senate and that House, kind of as a procedural standard. SHPTA, the State Health Planning, I don't know, Catherine, help me out with that acronym. The State Health Planning and
I'm not better than you are.
SHPTA is the agency in the Department of Health that plans for the health infrastructure. So it's the plans to expand hospitals, for instance, and make sure that there are enough of the physical resources so that there are enough, so that we as healthcare workers can go in and work there so that people can access healthcare. So it's kind of like, it's the physical resource focus. They have established, they're working to establish the Hui Ho'omana Task Force, which would be to renew and revise the state health plan for the first time in 20 years. So there were a whole bunch, there were 4 bills. Thank you, State Health Planning and Development Agency. Acronym soup. There was a whole bunch of bills. They all died because they got rolled into this other bill, which is SB 2285. So kind of combined several SHPTA initiatives into one. Initially, they had Well, the bill has changed, and for the last I looked at it, Clem is now would be or a delegate that Clem appoints would be the nursing representative on this initiative. And I just want to recognize Catherine is also currently engaged in SHPTA. She has an appointed position for the Honolulu Planning Division. So each county has a division. But this is a big undertaking, 20 years of using the same plan. All right, let's recognize this work needs to get done. There was also many workplace violence bills, and they all died. Some of it was to increase felonies, some of it was to allow healthcare employers to take out temporary restraining orders on behalf of their employees who have been assaulted at work, but none of those measures passed. So I just want to recognize that that was there, but not moving forward this year. With the education bills, good news is UH had put into the Board of, UH Manoa got into the Board of Regents budget an initiative to fund the UH West Oahu pre-nursing and NASN UH West Oahu nursing expansion program. And yesterday, during one of the conference committee meetings, the Finance and Ways and Means Committee said that they are going to fund the 6.5 positions to that full amount. So that's really big news. That will be great for the west side of Oahu, and also those those students tend to be nurses who come from very different backgrounds that are underrepresented in nursing. So I think that will be great for a number of initiatives. So congrats, Clem. That is very big news. Then there is another bill, this DOE DLAR workforce development. It is a request for funding to basically sustain some of the elements of that of the Good Jobs Initiative when that federal funding ends. And it really focuses on the high school healthcare workforce, the CNA to LPN glide path. It also appropriates funds to renovate and equip certain public high schools for healthcare training. Some thought is like creating kind of simulation centers in high schools so they can do more advanced training. That bill had a dramatic, like it died, it came back, it died, it came back, it died, and then it came back, and then it's still alive. So very exciting couple days there. And it is moving forward. So some of, as Bree was mentioning, a lot of the grants that came around during the pandemic are ending. And this is an effort to sustain some of that. And clearly, if it is able to sustain that CNA to LPN glide path, good thing for our state. Okay, I just want to note some trends that are, if we go to the next slide, some trends that might be popping up next year. And so we might want to, one slide back. So one in education, the education capacity for nursing and allied health, I think, is still a really big conversation. It's a good thing that NASN got expanded faculty and staff, but that does not take care of the whole state. We also know and continue to hear about needs for allied health, rad techs, respiratory tech, the technicians and the therapists and the therapist assistants, those positions, the community health workers, the CNAs, the MAs. We've heard one healthcare system was not able to hire physicians because there were not enough MAs to staff that office. So that is going to continue to be a trend. If it's not, I'll be shocked. We're still having a lot of conversations about the need for the LPN education expansion, as you heard today. And there's still a lot of consideration about the need for RN expansion. And actually the information that Anne and Arthur, you shared about and Clem about vacancy rates, that's information that we want to use as to help schools plan forward. So to that note, there is some incoming information that we will be using to support our state strategies. Those are the workforce projections through 2036. Carrie's working on a giant contract for that. The clinical education demand needs assessment that Bree mentioned earlier, and then again, that HAH healthcare demand study that they do every 2 years. So we will absolutely be needing to apply those data to the strategy, because if we don't want to overshoot it. We all remember 2018 when we were still sending new grads to the mainland, and we don't want to get back. We don't want to swing too far, right? So we want to just hit it just so we're just right in the pocket. For workforce, the trends, the work environment is still going to be a very important conversation to have. The topics specifically that have been coming up are ratios, overtime, salary, shared governance, staffing committees. Those topics are being pulled into the policy space. And I think we are so state funded in our state that it's, in some ways it's necessary because it's budgetary. In other ways, it's an interesting place to have the conversation because we also are a strong union state. Regardless, all these conversations need to be had because we have to find a way that adapts to the future workforce needs. And these are the talking points that are rising up. So these are important conversations, and we need to find the strategies, like I mentioned in education, where we find good data and good research to help develop evidence-based strategies to meet the needs of the future. Professional development, similarly, is still very much important because we don't want to return back to that time where we sent nurses away to get specialty trained, or not expand programs and initiatives because we don't have the specialty nurses. So that is continuing to be a need. We are launching that work, but we are not at that saturation or stabilization point. And there may be, we've had funding, but from grants, but we do not have state funding for this. So, that could be a conversation. There is the Center for Nursing. We've been working on quite a large initiative addressing the legislative barriers to practice, particularly in the APRN and interprofessional, like APRN, physician assistant, physician, psychologist, and pharmacist space. So kind of that provider level. But that will be a big undertaking when that is ready to launch. And then licensure capacity. We talked about temporary permits and the nurse license compact. There may be initial or additional bills to help the state conform to the nurse license compact, or revise laws so that nurses coming in are more equipped to work. And we're also going to need to help DCCA as a state. I think DCCA will continue to need that support to respond to ongoing increases in licensure applications, because it's like, I actually did the math based off of our invoices. It's over 400, but it's between 400 and 500 additional licenses that DCCA is processing a month. So it's just a really high volume of license applications that they're working through. And then lastly, AI and innovation to offset the labor changes. To Clem's point about no longer being kind of net neutral with our population, we're in a population decline, but that doesn't mean that we still don't have a large amount of people to take care of. So how do we adapt and use resources, innovative resources appropriately? Okay, last two mentions before I'm over time, sorry. Pass it on. One is Jeanette got confirmed, and we will be having a new board member, Sandra Leggy Brandon, who is the Vice President of Patient Care and Behavioral Health. She's a Psych NP, so that's very exciting. And then unfortunately, we had a resignation, and I know that all of you guys enjoyed working with her, but Renee is moving back to the mainland, and so she has resigned. So I just wanted to give my mahalo to her. Okay, and then we have advisory board priorities. We have relaunched our working group activities. Carrie is going to be coming out with a sub-report on wellness in the next coming months. So she did field that data. And then we just started last week having meetings with our wellness recruitment and retention work group again. So what we're doing is really focusing on which of the activities that had been initially identified need that state level support, whether it's a collaborative or policy or funding. And then also using like a Maslow's hierarchy to rank the urgency or importance of those activities. And so that's moving along really well. And I think it's a positive work. I'm also, if we could go to the next slide, just a little bit more information. So we are focusing the work, and then I'm going to be working on a job description for either a GA or a position. I'm going to try for both because we had a poor time fielding someone last summer when I tried opening a position. And then again, this work should be collaborative, and so we want to bring other partners beyond healthcare into that collaborative approach for engaging in the activity. So identifying those partners for engagement. So those are the next steps for wellness. If you're not on the meetings and you have interest, just email Brie or I or Carrie, and we can add you into those meetings. Okay, other business. Back on time.
PD delivery. Okay, so wow, 2025 is 20 years of the center. Wow, it's a bummer. You know what it means? I'm getting older and older. Woo. So the last strategic plan covered 2018 to 23. So it's time for revision and beyond year to year. It needs the big one.
Yeah, we need the big one.
Yeah, we need the big one. So the tentative plans is to use this year and next to do the planning. There's integrated island by island visits by the board and staff. You've done that before too, Laura. I remember you had a traveling show once before. And
We had a leadership grant where we did a traveling show. The last time we did strategic plans, we actually flew everybody into Oahu. So I think it'll be nice to go back out. I think we need to go visit people where they are.
yeah, well, you know, you got us on Maui, and you got Arthur and Jeanette and Big Island, and we all have connections in Kauai, so you're all set to go when the time is right. So the new strategic plan is aimed for the end of 25. But we do need a party. 20 years, that just begs it. We do have the annual in-person board meeting on August 10th. So I'm sure there'll be some good talk during that meeting about that as well. So, oh yeah, national conference. It's in San Diego. It's awesome. I get to go right in the middle of summer session. Perfect miracle. And the program looks so strong. You know, there's 3 for me pre-licensure talks that I can't wait to hear. And you know, it'll be really great to hear too that how others if people are feeling this kind of saturation in the workforce where they are too, that you know we're getting this first little drops. And the smartest girl, Carrie Oliveira, is going to present. I think Carrie has helped this national forum with their data for years to tune it up to the highest standard. So, you know, we're really lucky to have her. She smiles and she's, you know, so kind and gregarious, but she's brilliant and helps the whole nation. And so it's really worthy of being proud of. But I can't wait to go. And a good group is coming from our center. So that will help bring back cool stuff to the state.
So the 3 of us will have a wellness presentation. Well, Carrie and Bree, and then Bree and I have a NRP presentation, and Carrie has another data presentation.
And I'm going to be the groupie.
Yeah.
In the audience. Woo!
This will be Bree and Leanne's first conference. So it'll be exciting for them to kind of see that whole space too.
Well, so it's 6:53. We're so good. The scientific symposium. Man. So the center is hosting its inaugural Nursing Scientific Symposium. It's an opportunity for both clinical and academic settings to share their original scientific studies, research, EVP, NQI, and any programmatic innovations. So the registration is going to open in May 24, first come, first serve. So the calls for abstracts is open. We'll have to get Mary to apply. To
Yeah,
Yes.
and if
Yes.
you notice, I'm gonna use this little pen thing. If you notice the cost here,
No, I
Mhm.
don't.
can you see that? It's free.
Down on the left
Oh,
corner of the image. There you go.
free.
There, your pen showed up. Yeah.
All right. Where is it gonna be? Honolulu.
The
Hawaii.
Hyatt.
All
The
right.
Hyatt.
All right. Sounds awesome. What a great idea. The first, you're gonna celebrate a 20-year anniversary of the center and the first anniversary of the scientific symposium. Cool.
Yeah.
All right. Any more treats there? No.
No, that's it.
Okay.
We're done.
All right. Well, how great you guys are. Laura and Bree and Carrie and Catherine and all the kind, you guys do such a solid job for our state. Anyone who doesn't know your name and is a nurse has felt your impact. I'm so thankful. I'm just so thankful for your work and your vision. And I'm proud to help in any little way. So great to see all your faces. August will be in person. That should be fun. So I guess we'll call it an official wrap. 6:55 will adjourn. Aloha.
Thank you, everyone. I appreciate the time this evening and particularly your engagement with all of the conversations and welcoming Mary, who's gone. But I was really grateful that she was able to be here for that presentation.
Thanks, everybody. Bye.
Good night. Bye.
Good night.